long cases. A very dynamic personality of faculty, Dr. Nitin Chaudhary. He is assistant professor in Atal Bihari Vajpayee Institute of Medical Sciences and Dr. RML Hospital, New Delhi. His area of interest are pediatric anesthesia and obstetric anesthesia. The postgraduate student who will be conducting this case is third year postgraduate student, Serenu. I welcome you, ma'am.
Good afternoon, and we'll start this preeclampsia. And Dr. Serenu, you must start your case presentation. This is a very important topic. First of all, I must say that in exam, many of you will get a case on PIH, and also in the written exam, you may get questions on any aspect of PIH or eclampsia. So you must know this case very well. And later on also, once you have qualified, you'll have to manage these patients frequently. So over to Dr. Serenu for presentation of the case.
Yes, sir. Good afternoon, everyone. Myself, Dr. Serenu. I'm here to present a case of pregnant female with preeclampsia posted for elective LSCS. I'm presenting history of 26-year-old female, graduate, homemaker by occupation, resident of Delhi, primary gravid with 37 weeks of period of gestation, came to the hospital with complaint of amenorrhea since 9 months and headache since 2 days. Patient was apparently well 3 months back when she started having complaint of headache, and during her routine antenatal visit, she was her blood pressure was found to be elevated, and she was diagnosed as a case of preeclampsia. Then she was started on tablet labetalol 100 mg 3 times a day. At present, she is having complaint of headache, which was sudden in onset. At present, she started having complaint of headache again, which was sudden in onset, throbbing in nature, mild in intensity, localized to bilateral frontal areas, non-radiating and non-pulsatile in nature, slightly relieved by rest, not relieved on taking painkillers, aggravated by exertion. There is no history of use of spectacles or contact lenses earlier, no history of fever, nausea, vomiting, ringing sensation in the ear. There is no history of slurring of speech, facial or limb weakness, abnormal body movements. Headache was not associated with blurring of vision, double vision, increased sensitivity to light, gaze and glare. There is no history of upper abdominal pain, yellowish discoloration of eyes or itching, and there is no history of decreased urine output. Past history, there is no history suggestive of hypertension prior to the pregnancy, no history suggestive of diabetes mellitus, renal disease, thyroid disorder, tuberculosis, convulsion in the past, and there is no history suggestive of COVID infection and history of blood transfusion, any surgeries, and any drug history, drug allergies in the past. Of static history, the LMP of the patient was 6th of March 2022. The first trimester, pregnancy was confirmed by urine dipstick test at home. There was no history of excessive nausea, vomiting, fever, rash, or radiation exposure in the first trimester or bleeding per vagina. There was no history of any drug intake except folic acid during first trimester. In second trimester, during her regular antenatal visit, she had complaint of headache and her blood pressure was found to be elevated. At that time, she was diagnosed as a case of preeclampsia and she was started on tablet labetalol 100 mg 3 times a day. She felt quickening at 5th month of pregnancy. There was no history of breathlessness, fatigue, weakness, drowsiness, abrupt increase in weight and bleeding or leaking per vagina. She was immunized with 2 doses of tetanus toxoid and she took regular medication of iron and calcium. Her third trimester was uneventful until 2 days back when she started having complaint of headache, which I have described earlier, and she felt regular fetal movements during third trimester. Treatment history, she took folic acid tablets in her first and second trimester, iron and calcium tablets from second trimester, and from 24th weeks of period of gestation, she is taking tablet labetalol 100 mg 3 times a day regularly. In family history, the mother of patient had history of raised blood pressure during first pregnancy. No other significant family history is present. Patient is vegetarian by diet with good appetite, regular bowel and bladder habits. Her sleep patterns were normal until she had complaint of headache. She belongs to the upper middle class of socio-economic status. There is no history of drug allergy. Patient is a non-smoker and non-alcoholic. Examination. After taking informed consent from the patient, general physical examination was done with patient lying comfortably on bed in left lateral position. Patient is conscious, cooperative, and oriented to time, place, and person. She was average build patient. Bilateral mild pitting edema was present. There was no pallor, cyanosis, clubbing, icterus, or lymphadenopathy. Neck veins were non-dilated. Her height was 160 centimeter with weights of 58 kgs. BMI was 22.6 kilogram per meter square. Patient was afebrile. Pulse rate was 80 per minute, regular in rhythm, normal in volume and character. There was no radial or radiofemoral delay. Taken in right arm in left lateral position. Her BP was 134 by 78 mm of mercury, measured in right arm in left lateral position. Respiratory rate was 17 per minute, regular thoracoabdominal. Now, airway examination, there was no obvious facial deformity seen. Her nares was normal, no flaring was seen. Mouth opening 4 centimeter. Mallampatti class was 2. Oral hygiene was good. No missing tooth or loose tooth or artificial dentures. Upper lip type bite test class 1. Thyromental, hyomental, and sternomental distance were within the normal range. The range of motion of the movement of the neck was normal with full extension and flexion. Neck circumference was 38 centimeter taken at the level of the thyroid cartilage. Systemic examination. On per abdominal examination, inspection, abdomen was uniformly distended, umbilicus inverted. All quadrants were moving equally with respiration. No dilated scar or veins were seen. Strigravidum and linea nigra was seen. On palpation, fundal height was 36 weeks. Grip examination, fundal grip, soft, broad, regular mass was felt, suggestive of breach. On right lateral grip, multiple nodular structures was felt, suggestive of limbs, and left lateral grip, smooth curved structure was felt on the left side, suggestive of the spine. In pelvic grip, hard globular round mass was felt, suggestive of head. During all the grip examination, uterus relaxed and non-tender. Fetal movements were felt during examination. On auscultation, fetal heart sound was heard at left spine umbilical line, and with fetal heart rate of 145 per minute. Respiratory system inspection, trachea was appears to be in midline. Normal chest was normal in size, shape, and bilaterally symmetrical. There was no chest wall deformity, visible dilatation of vein, any swelling, or any supraclavicular bulge. Palpation inspectory finding were confirmed. Normal vocal fremitus present. On auscultation, bilateral vesicular breath sounds were heard, and no audit sound was present. Cardiovascular system, on inspection, no pericardial bulge or visible pulsation or engorgement of superficial vein seen. Apical impulse not appreciated. On palpation, apex beat was felt in fourth intercostal space at left mid-clavicular line. No parasternal heave, thrill, or pulsation was seen in the area. On auscultation, normal S1 and S2 heard. No added sound were present. Central nervous system, higher mental function was normal, and motor and sensory functions and reflexes were also within normal limit. Examination of back, exaggerated lumbar lordosis was seen. Mild pitting edema in sacral area was seen, but no other skin infection or shoulder deformity or scar were marked present. No scoliosis, kyphosis, and gibbous seen. My provisional diagnosis is a 26-year-old female, primary gravida with 37 weeks of period of gestation, diagnosed case of preeclampsia posterior for dialysis. Ma'am, you are not audible.
Okay, now I'm audible.
Yes, ma'am.
Thank you. And now, supposing that this patient comes to you in the pre-PSC clinic, and
Yes, sir.
the obstetrician is sending you because they think that she might require cesarean. Why do you think that she might be requiring cesarean at all? Why would she require a cesarean? What are the possible reasons?
Ma'am, there can be indications for cesarean delivery like breech presentation of the patient, general, other than the preeclampsia part, breech presentation of the patient, or any other presentation of the fetus other than cephalic, or the patient is having a sustained fetal distress or bradycardia.
Anything else?
Uh, in cephalopelvic disproportion of the baby.
So she has PIH, so she's already 37 weeks. What is the treatment of PIH?
Ma'am, termination of pregnancy at term.
Yeah, that is
If
right. So the best course is vaginal delivery, for which also
yes,
liver analgesia may be required. And then the other thing would be cesarean section because of as a routine indication. So that's not decided by us, but we are getting the patient for pre-anesthetic checkup. Now you get this patient for pre-anesthetic checkup. How will you work up the patient?
ma'am, after taking history and examination of the patient.
Of the patient, you
Yes, ma'am.
the history and examination, and how would you proceed further?
Ma'am, then I'll order some investigation on the patient. I'd like to get a complete hemogram to be done to get the baseline hemoglobin and total leukocyte count, platelet count to be done, and then liver function test for liver enzymes, kidney function test to see the serum creatinine levels, and 12 lead echocardiography, electrocardiography, and
Anything else?
ma'am, if the platelet count of the patient is abnormal or its patient is in thrombocytopenia, then coagulation profile
Okay.
and fundus examination to rule out the raised ICP.
Are normal. Is platelets are reduced. What did you say just now?
Ma'am, if platelet count is abnormal, if the patient is in thrombocytopenia, if the then I'd like to get the coagulation profile of the patient to be done. Or if the patient is having features of severe preeclampsia or eclampsia, then also, irrespective of level of platelet counts, I would like to get the coagulation profile to be done.
Yes. Because how will a platelet count affect the coagulation profile? It doesn't affect.
Ma'am,
It doesn't
no, ma'am,
affect.
it yes, ma'am, it doesn't affect, but in studies, if the level of platelet count is more than 1 lakh, then the incidence to be there is less.
The your voice is breaking. Voice is breaking. Can
Ma'am,
you could you
ma'am, uh,
repeat that?
audible now.
Yes, you are audible.
Yes, ma'am. Ma'am, it is seen that if the patient is having a platelet count of more than 1 lakh, then the incidence of coagulopathy will be less, or the chances of coagulopathy will be less. So, if there is thrombocytopenia, then only I would like to get the coagulation profile to be done.
No other reason.
Or if the patient is having abnormal liver function tests.
And renal function?
Yes, ma'am, I'll get liver function test done to see the level of serum creatinine levels.
No, no. What about renal function? If the renal function is abnormal, then will coagulation function be affected or not?
Ma'am, Ma'am, if renal function tests are abnormal, deranged, then the patient must be with preeclampsia with severe features. So the chances of coagulopathy is there. So I would like to get the coagulation profile.
That's an indirect correlation. But renal function affects the platelets more than the coagulation profile directly. So if the patient is having deranged renal function, you should think of the platelet function, not just
Yes.
hypo, not just thrombocytopenia, but platelet function as well. Okay. Now, okay.
Yes, ma'am.
For the patient investigated, you didn't ask for a urine examination. Is urine
Yes.
examination important or not in this patient?
Yes, ma'am. I would like to get the 24-hour urine protein levels to be done.
Yes, because that was usually diagnostic of PIH and also gives an idea of the severity of eclampsia, preeclampsia. Okay.
Yes.
Now suppose that all these things are normal. All these investigations which you said are normal, and platelet
Yes, ma'am.
count is also good, and the patient is posted for elective cesarean section at 37 weeks of gestation. How will you prepare the patient for what advice would you give, preoperative advice, and how will you carry out the anesthesia for this patient?
Ma'am, my pre-op orders will be written informed consent to be taken prior to the surgery. Then nil per oral for
What informed consent?
ma'am, written informed consent for the LSCS and the risk of anesthesia.
So how do you grade this patient? ASA grading?
Ma'am, 2, ASA 2.
ASA 2 is normal. Any normal pregnancy is ASA 2.
Ma'am, normal pregnancy is also ASA 2, and if the patient with preeclampsia without severe features, then
So
also ASA 2.
she is
Yes,
not
ma'am.
features because she's controlled. She's on treatment. So that
Yes,
becomes
ma'am.
2.
Yes,
A
ma'am.
patient with normal pregnancy is also ASA grade 2. So is this risk not higher?
Ma'am, it is higher.
No, she becomes ASA 3, no?
ASA 3.
This is important because you are saying informed consent, you have to inform the patient and it is that the risk is higher than normal in this patient. Okay. So as far as ASA grading and consent is concerned, then
NPO orders for nipple order for 8 hours for solid foods, and continue antihypertensive medications on the morning of the surgery with sips of water. BP charting to be done, and send a blood sample for blood group and cross matching.
anything else?
Ma'am, for anti-aspiration prophylaxis tablet, Pento 40 mg on the night before the surgery and also on the morning of the surgery with sips of water.
Pentop indicated.
Yes, ma'am.
It's pentop indicated. Firstly, you should not say pentop. What is pentop?
Ma'am, proton pump inhibitor.
Pantoprazole. Please say the generic name of the drug when you are answering like this. What is pentop?
Yes,
Okay, you are saying pantoprazole. Anything else? Anything else you would like to give?
ma'am. Before taking the patient to the OT, then anti-aspiration prophylaxis is given with the injection Rantidine 50 mg IV, 30 to 60 minutes prior to taken to the OT, and also injection metoclopramide 10 mg IV,
Not give these to the
30
patient.
to 45 minutes.
During elective surgery, you can easily give tablets to the patient. You know that this patient is going for cesarean. You will advise us in the morning, 7 a.m. No?
Yes, ma'am, tablet also.
Asking for 8
Yes,
hours. If you give tablets, that's good enough. So IV is better result for emergency, but for this patient, it is less distressing. Okay, okay.
Yes, ma'am.
Good. Then what else? Next.
Known particulate antacids, 0.3 molar sodium citrate, 30 ml, 30 minutes prior to the surgery is also given.
Okay, you may give, but you may not give also. Because this patient is not full stomach. She's fasting for 8 hours. Though you are supposed to give the anti-aspiration prophylaxis, but this is not required really, because this is for what is the use of sodium citrate?
Emergency.
What is the use of sodium citrate?
Ma'am, it will decrease the increase the pH of the gastric content to decrease the incidence of the chemical pneumonitis or due to aspiration of the patient.
Okay. So for the now coming after the aspiration prophylaxis, what are you going to do?
Then, ma'am, after explaining procedure to the patient, we'll take the patient and after confirming the patient, we'll take the patient into the operation theater, and then I'll take the patient to the OT table in with the wedge under the right hip to make the left uterine displacement in the patient, or make the patient to lie in left lateral decubitus position. Then attach all the ASA2 standard monitors, which includes electrocardiography, pulse oximetry, non-invasive blood pressure monitoring, and then I'll take the wide bore IV cannula and start the IV fluids, crystalloids, and reload the patient. And then I'll proceed the LSCS under regional anesthesia.
Reload with what?
Reload with crystalloid or RL 250 to 500 ml of ringer lactate solution.
Okay. Then?
And then I'll proceed with for electrolysis. I will proceed for the regional anesthesia.
Okay.
I'll make the patient in left lateral position, and then after painting and draping the area from lower border of the scapula to the gluteal ridge, and then give the subarachnoid block in L3, L4 intervertebral space with Quincke's 25 gauge Quincke's needle.
How much?
I'll give them bupivacaine, 0.5% heavy bupivacaine, 2 ml, along with the fentanyl of 25 mics.
Okay.
After aspiration.
Okay.
Then after giving the spinal, I will make the patient supine and monitor the vitals and check for BP recording, and then check the levels of the
So
motor and sensitive blockade. Yeah, ma'am.
You missed something. Placing a wedge under the right hip or giving a 15-degree tilt. This is the time. Okay. When you should have given.
Yes.
And what about fluids?
Ma'am, I'll give fluids 75 to 100 ml per hour of the at the rate of 75 to 100 ml.
75 to 100 ml per hour.
Per hour.
Do you think that's enough?
Ma'am, if the patient is hemodynamically stable, if the patient goes into the hypotension, then I'll rush the fluid and
May go into hypotension.
also the
fluids properly. She may go.
yes, sir.
So in normal patients, how much do you use in a cesarean section?
Ma'am, according to weight of the patient.
How much? How much do you give? How much fluid do you give? You must have got many cesareans done by now.
Yes, ma'am.
So how much fluid do you give?
Ma'am, I'll calculate the maintenance and deficit fluid according to the formula 421 and then maintenance fluid and deficit according to the NPS status of the patient, and then according to that I'll give the fluid of the patient.
So how
100 to 120 ml usually, ma'am.
per hour?
Yes, ma'am.
Normally you don't do co-loading.
Yes, ma'am. Preloading. Yes, ma'am.
Preloading and co-loading both should be done. Which is better, preloading or co-loading?
Ma'am, now recent study says that the co-loading is better than preloading.
So you are saying very little fluid, 100 ml per hour. What
No,
is
ma'am. Then
spinal to the
250.
so when you give spinal to the patient, what will happen?
Ma'am, patient can go into to the spine hypertension.
Yes, patient can go into hypotension, and what will happen? Because they're vasoconstricted. These patients are vasoconstricted. So when you give
And
spinal
yes,
anesthesia, what will happen? There can be
then
hypotension.
the sudden
Ah, so that is why
sudden fall in the blood pressure.
the fluid status very well. Give adequate fluid but slowly. Okay, that is why co-loading is very important. Preloading, that's okay, 500 ml you give before, but you should keep co-loading because as the spinal takes effect, there will be hypotension. Okay.
Yes.
Why did you choose spinal anesthesia? Why not GA?
Ma'am, regional anesthesia is better than general anesthesia as it can avoid the risk of airway manipulation. The patients are already, the pregnant patient are considered as full stomach patients, so there will be risk of aspiration in the general anesthesia. Also, the because of the changes of the pregnancy and preeclampsia, also there will be edema of the airway, parapharyngeal and subglottic airway. So there will be difficult intubation and laryngoscopy of the patient. So we can avoid that also. The patient is already preeclamptic, so her blood pressure is already at higher levels. During laryngoscopy and intubation, we can avoid the pressure response to the laryngoscopy via regional anesthesia. Also, with regional anesthesia, there will be the good uteroplacental flow, so it will be better for the fetus also, and there will be less variation in the heart rate of the fetus. And with regional anesthesia, it decreases the level of the circulating stress catecholamine release also.
Yes.
And with the regional anesthesia, there will be less exposure of the drug to the fetus
Yes.
as it can be with general anesthesia.
So
And
one thing which you are missing out.
yes, ma'am.
Any pregnancy, any cesarean. One thing you are missing out. Why is regional anesthesia so popular nowadays? You know, when I was,
Ma'am,
there was the norm. It has changed totally now. So what is the big advantage? One more advantage. You spread out all the advantages. There's one more advantage.
ma'am, because with regional anesthesia, we can manage postpartum and pain in the patient also. Analgesia, it will be better analgesia with the regional anesthesia.
See, what did you miss out? Bleeding is less.
Bleeding is less.
Okay.
Yes, ma'am.
Why is bleeding less?
Ma'am, because of the
Two reasons are there.
ma'am, in general anesthesia, the drugs we used are usually vasodilation, cause vasodilation in the and uterine atony also.
Yes. Which
So because of that,
what causes uterine atony?
ma'am, inhalational agents
Yes, all the
we
inhalational
use.
cause uterine relaxation. So that is why it is always better. That is one very big reason. And second reason, blood pressure head is reduced, systolic pressure head is reduced with spinal anesthesia. So that is why bleeding is less. Okay. So this is the advantages of regional anesthesia, of spinal anesthesia in particular. Right. So now that effect has occurred, what level do you need for spinal anesthesia?
Ma'am, sensory level, sensory blockade at T4 level.
Okay. And then continue with the spinal anesthesia. What precautions do you need when giving spinal anesthesia?
Ma'am, we should, an experienced anesthesiologist should give spinal anesthesia, try to give in a single shot, and also atraumatic needles or to decrease the risk of post-dural puncture headache. We should use less traumatic needles and larger size.
Okay. And what if there is hypotension?
Ma'am?
What if there is hypotension?
Due to spinal memory.
Yes. Following hypotension.
Ma'am, we'll give IV fluid to the patient. And if the patient is not responding to the fluid therapy, then we can give a injection phenylephrine bolus 25 to 50 mics IV.
Phenylephrine indicated in these patients. They are already phenylephrine indicated.
Ma'am, your voice is breaking, ma'am.
Is phenylephrine indicated?
Ma'am, if the patient is not responding to the fluid therapy and the BP is mean arterial pressure is going less than 65 mm of Hg, then we give phenylephrine because it will decrease the uteroplacental flow and it can lead to fetal hypoxia.
Choice is ephedrine. Okay. Ephedrine. No, ephedrine is not preferred otherwise, but for these patients it may be preferred. But you can give phenylephrine also, but it is not your first choice. Okay. And okay, so you gave the drug and all that, and surgery will be conducted. For post-op pain relief, what will you give to this patient?
For post-op pain, we can give systemic IV drugs, IV opioids, or IV non-steroidal anti-inflammatory drugs also. So they should be given cautiously if the patients.
NSAIDs.
Yes, ma'am.
What is the risk with NSAIDs?
Ma'am, in NSAIDs, they inhibit the prostaglandin synthesis, so there will be lack of vasodilation. So it increases the risk of increased hypertension in pre-eclamptic patient.
Yes.
And
so what can you use?
Also, it will cause sodium retention. So
And
you
can increase bleeding also. Okay, so which one can you use? What can you use?
Injection paracetamol can be given.
So this is one option. Second option?
Ma'am, we can give regional blocks to the patient.
Which blocks?
Ma'am, transverse abdominis plane block and tab block.
So that's a good block to give. It's very easy to give, and the effect lasts for pretty long. So it's a plain block, and the effect lasts for long time. So this is one option. Another option, and you can always give local infiltration. If you are giving paracetamol, you can give local infiltration also. But block is always better. It gives better analgesia without touching the surgical site. Okay. So now,
Yes, sir.
that is if this kind of patient is there. Now, supposing that this patient comes for an emergency cesarean section. Okay. And
Yes, sir.
just because the bleeding, the patient is having high BP, and the surgeon says that the obstetrician is saying that the patient has to be taken up as an emergency. Then what will you do?
Ma'am, first we will assess the patient. We'll take the reading with the blood pressure. Uh, we'll control the. Ma'am, first we will control the our aims will be controlling the blood pressure of the patient, prevention of the seizure if there is patient is at high risk with the severe preeclampsia or showing the signs of impending eclampsia also. Then seizure prophylaxis to be started, and maintain the intravascular volume as this patient have depleted intravascular volume. And then after
Magnesium.
investigating the patient.
They would
Yes, ma'am.
have magnesium sulfate. Many of these patients.
Yes, ma'am.
So in that case,
Ma'am, can you please repeat your question?
what if this patient is on magnesium sulfate?
Ma'am, then uh, we will ask for serum magnesium levels of the patients, and we can also check by clinical examination also if there is any sign of toxicity of the magnesium in the patient by checking the deep tendon reflex.
Okay.
By checking deep tendon reflexes, pulse rate, respiratory rate of the patient, and urine output of the patient.
Okay, but the patient has come as an emergency. So how will you proceed now?
Ma'am, I'll first investigate the patient to get hemoglobin levels, platelet count, coagulation profile, and urine dipstick test or protein creatinine ratio, renal function test, liver function tests.
Okay.
And, then I'll take the patient. Then first after controlling the blood pressure of the patient, if the patient is uh, conscious, cooperative, and then we can proceed with regional anesthesia.
Okay. What if for some reason you cannot give, platelet count comes low? At what platelet count will you give regional anesthesia? And at what
Ma'am,
platelet count avoid it?
Ma'am, if the platelet count is more than 80,000, then when regional anesthesia is safe. Platelet count of less than 50,000, we should avoid the regional anesthesia. And between 50 to 80,000 of the platelet count, we weigh the risk-benefit ratio according to the patient, and then we can plan.
Okay. But if there is some obstetric indication and they are saying that urgency in the hospital, that
Ma'am, we can go for subarachnoid.
can you give GA?
If there is urgent indication of
Say for
cesarean,
the patient is bleeding. There's some obstetric problem.
yes, ma'am, we can give.
Then how
Ma'am,
will
for a patient under the general anesthesia, I'll take the patient on OT table and routine attach the all ASS standard 2 monitors, take 2 IV bore cannula in the patient, and place a wedge under the right of the patient for left uterine displacement in the patient. And then I will start pre-oxygenating the patient with 100% of oxygen for 3 minutes tidal volume breaths with the tight fitting face mask, and then I'll give a induction agent, propofol at titrate.
see, you were giving aspiration prophylaxis in routine case. Here you missed aspiration prophylaxis. Okay.
Yes, ma'am.
But here there is an indication
After giving.
IV aspiration prophylaxis. You
Yes,
never
ma'am.
took the last meal time. For emergency case, you must ask the last meal time, no? Right?
Yes, ma'am.
Not fasting for 8 hours. So you would like to know the last meal time, and you would like to give anti-aspiration prophylaxis.
Yes, question prophylaxis.
For all pregnant patients, you
Yes.
have to do that. Okay.
Then I'll give the induction agent of propofol under titrated dose.
Propofol,
And
you are wrong. Please be informed that propofol is not the drug of choice. It is not even indicated. Please see textbooks. What is the harm of propofol? What is the harm of propofol?
ma'am, it will cause hypertension in the patient. The patient is already depleted intravascular space.
Okay. Second thing, point number 2. This was point number 1. Point number 2. Propofol is a myocardial depressant. Okay. I told you the patient might be on magnesium sulfate. So what are you going to do? Patient may go into arrest also. You're giving 2 myocardial depressants. And propofol is not indicated even in normal pregnancy. Okay. And
Yes, ma'am.
number 3. Propofol affects the fetus. It causes a depressed fetus to come out, baby to come out. The neonate is depressed due to the propofol. Might come out weak or with low APGAR scores. Okay, because
Yes,
many
ma'am.
people are saying propofol, but propofol is contraindicated for the patients. Your choice of drugs is
5 pentones.
thiopentone. Otherwise, in pregnancy, which other agent can you use?
Etomidate.
Yes, and
And ketamine is usually avoided because the patient is already hypertensive and it will lead to.
yes, but otherwise, if patient is hypotensive, then you can use ketamine also. So
Yes.
propofol is not indicated for cesarean section. Okay, so you will give thiopentone. Okay,
Yes. Yes, ma'am.
and
Then I'll give a short-acting muscle relaxant, succinylcholine,
okay.
at the dose of 1.5 mg IV. And ma'am, I would also like to get, I will get the rapid sequence induction to be done. So I'll
5 mg per kg body weight. But you said 1.5 mg succinylcholine. Okay,
1 to 1.5 mg per kg. Yes, ma'am.
per kg.
जी ma'am. Per kg body weight. Yes.
Okay,
Ma'am, we will proceed rapid sequence intubation. So required pressure will be applied before the induction of induction age before the starting of induction agents, and then continue the required pressure. And after giving succinylcholine, there will be fasciculations of the body. After cessation of fasciculations, then we will proceed with the uh, intubation with the 7 or
yeah. You have forgotten
and
anything for preventing intubation response?
ma'am, we can give a bolus of labetalol 10 to 20 mg IV 1 minute prior to the, and also we can give lignocaine 1.5 mg per kg 90 seconds prior to the laryngoscopy.
Yes.
Uh,
Like to give or not?
yes, ma'am.
Would you like to give or not?
I would like to give, ma'am.
You are forgetting, no, that's why I'm asking you. Okay. Anything else you forgot? See, you will keep small size tubes. difficult airway cart, small sized endotracheal tubes, because patients may have airway edema. Okay, so that is important. Okay, so intubated the patient, then
I'll confirm the confirm the placement of the site placement of the endotracheal tube by checking the bilateral air entry and also the EtCO2 or capnograph in the monitor.
okay,
Secure the endotracheal tube and release the cricoid pressure.
yes,
And then we for maintenance of anesthesia use the volatile anesthetic to maintain the MAC of 0.5 to 0.7 and with 100% oxygen or oxygen to air mixture and we proceed.
हाँ आगे भी तो बोलो, अभी हो गया केस?
Ma'am, after delivery of the baby, after clamping the cord, we will give oxytocin to the patient. And also at that time we switch off or try to decrease the volatile anesthetic agents to decrease the uterine atony, and we can for maintaining the MAC we can start using nitrous then.
Then higher.
And
You were giving nitrous, weren't you?
initially before delivery of baby, no ma'am.
No, you can give 50-50 oxygen nitrous, no? You just increase the percentage of nitrous oxide. You don't have to give 100% oxygen.
Okay ma'am.
Now you can make it 2/3 nitrous. And what else can you give to increase the depth?
Ma'am, we will give for analysis of opioid fentanyl,
Yes.
injection fentanyl.
Yes. Can you give methoxin to this patient?
No ma'am, methoxin can cause exaggerated increase in blood pressure of the patient because of the.
Okay. Then what about extubation?
We will extubate the patient after adequate reversal of the neuromuscular blockade with neostigmine and glycopyrrolate. And before extubation, I'll give the drugs to blunt the response to the extubation also, so that there will be no sudden increase in blood pressure or hemodynamic response.
That's
And we can use the same drugs like labetalol.
Careful, because as I said, the patient is on magnesium sulfate, so one should be very careful when extubating.
Ma'am, for yes, ma'am, because of the magnesium sulfate, the duration and action of the non-depolarizing muscle relaxants is prolonged. So, if we have to repeat, then
Okay.
the dose should be less, and we should monitor the adequate reversal.
You should give less non-depolarizing relaxant also. You should titrate to the effect. Okay, so you can do with just half to 2/3 of the dose of non-depolarizing relaxant and see whether the patient is relaxed or not. If the patient is not relaxed, then you increase the dose. Otherwise, this may be adequate for the patient because they have summating effect. Okay.
Yes, ma'am.
So, okay. Now, supposing that the same patient, you get this patient in frank eclampsia, and you are called into the emergency that this patient had gone home. You had evaluated her for PSC, but they send the patient home, and then she comes back into the emergency with convulsions. Okay, and you are called that please help us in resuscitating this patient, and we want to take her up for cesarean as well. So how will you proceed?
Ma'am, if the patient presents with seizures in the cesarean, then if the patient is having active seizures, then first I'll call for more help, and then secure the scene safety of the patient, and then make the patient in left lateral. Ma'am?
Obstetric casualty.
Yes, ma'am. Then the patient will make the patient in left lateral position to avoid the risk of aspiration of the patient. Then maintain the airway of the patient either by bag mask ventilation with 100% oxygen or with airway, and then we will assess the breathing of the patient.
Maintain airway. Bag mask is for ventilation. No?
First with bag mask and then secure the permanent airway.
Okay. And then will the patient allow?
Then
Will the patient allow? If she's
side by side, I will take the IV cannula and
yes.
then IV cannula, and we will the blood pressure of the patient will be most probably high, so we will control the blood pressure and start the seizure prophylaxis with magnesium sulfate. Hypertensive medications.
Which route?
IV.
Okay. And
Antihypertensive medications we will start, ma'am, to control the BP. The patient.
patient is already on labetalol, but then she went into hypertension. So what other drug can you give to the patient?
Ma'am, we can give IV hydralazine.
Hydralazine.
We can start with 5.
Yeah. This is written in foreign textbooks. Hydralazine is not available in India. Okay.
And
What
nifedipine can be given
okay.
if the patient can take orally 10 mg per oral.
Patient was
And
you know, so what other drug can you use?
Second line antihypertensive drugs, we can use our esmolol, sodium nitroprusside, or infusions of NTG can also be started.
So that will control the BP. And airway, what did you do?
Ma'am, I'll
The post-ictal phase. Now, she's conversion is controlled. She's in the post-ictal phase, and she's unconscious.
if the patient is unconscious, then I'll secure the airway with endotracheal tube.
Okay. Okay. Now shift the patient for cesarean section. Right. Now you proceed in exactly the same way that you described for emergency cesarean section. But induction dose of agents may be very little because she's already deep and you've already intubated, so you can go ahead straight away with non-depolarizing reactant. At the end of surgery, now what precaution will you take?
At the end of surgery, ma'am. Ma'am,
Should you try to reverse the patient?
Yes, ma'am.
Try to reverse the patient.
Ma'am, no, ma'am. We will ventilate the patient in post-op period also.
So electively ventilate because patient
Electively ventilate the patient.
Okay. So patient.
Yes, ma'am.
She was convulsing because she had raised ICP.
Yes, ma'am.
Okay. So what is the treatment of raised ICP?
Ma'am, we can hyperventilate the patient and
sedate and ventilate.
Sedate and ventilate.
Okay. And she is already on herself, so she may not even require more muscle relaxation. And ventilate for 24 hours, and after that you can evaluate her consciousness level and accordingly extubate her. Okay, so that is the right way to proceed in these cases. Okay, so we have discussed various scenarios for PIH and eclampsia. When do you say it is eclampsia? When you say PIH has progressed to eclampsia, what are the defining features of eclampsia?
Ma'am, preeclampsia is when there is a new onset of tonic-clonic focal or multifocal seizures in a patient previously not diagnosed with any seizure disorder or underlying any other conditions causing seizures.
Right. Anything else? Even unconsciousness. Okay, in a patient who was awake but suddenly became unconscious. So that could also. What are the complications of PIH? Systemic complications of PIH.
Pregnancy-induced hypertension lead to endothelial dysfunctions and release of inflammatory and cytokines, which can lead to systemic manifestations. Like in the central nervous system, it will lead to the cerebral vasogenic cerebral edema in the patient, hyperreflexia, hyper vasodilation edema, and hyperreflexia, which can lead to the patient with visual disturbances or seizures and coma in the patient. And in the respiratory system, there is a edema in the parapharyngeal and laryngeal area, and there the mucous membrane of the airway become fragile, and there will be more prone to the injury and bleeding. And in the renal system, there will be decreased renal blood flow, and also the GFR of the patient will be increased, which can lead to the increased uric acid level or serum creatinine levels.
Right.
The patient decreased urine output because of the glomerular or endothelial damage in the patient. And in the hepatic system, there will be increased risk of subcapsular hematoma or periportal necrosis in the liver in this patient, coagulation profile derangement, thrombocytopenia because of the increased platelet activation, aggregation, and consumption.
What else?
In a of I increased retinal vessels can go in vasospasm, and there will be a retinal detachment can also occur in the patient.
Papillary edema. Okay. So that
Yes.
one is doubt that you never ask for a fundal examination, fundus examination. This can give you a very good idea of the degree of PIH when you evaluate the patient periodically. And one more system which you have missed out totally. What about cardiovascular system?
In cardiovascular system, there will be increased systemic vascular resistance in the patient, and cardiac output is also increased, leading to systolic and systemic and systolic and diastolic blood pressure, increase in systolic and diastolic blood pressure.
What is the effect of this on the heart?
It will increase the oxygen demand, and to the
Go into failure.
can go into failure. Yes, ma'am.
Pulmonary edema, all these things can occur. Okay.
Yes,
And
ma'am.
you can also have the complications of hypertension, like
Left ventricular hypertrophy.
and
Arrhythmias can also occur in the patient.
okay, and one more.
From heart failure में जा सकता है patient.
CVA. CVA.
Yes, ma'am. Cardiovascular accident. Yes, ma'am.
Cerebrovascular. So these are CVA can also be there. That is why we are so particular about controlling the intubation and extubation response. Because this is seen. Okay. So these are, I think, mostly we have covered most of the areas of PIF. And over to Dr. Nitin Chaudhary. Thank you, Srenu. And now, Dr. Nitin, can you start with your presentation? So
Thank you, ma'am.
said an overall view of the disease.
Thank you, ma'am.
So anesthesia for pregnancy-induced hypertension. Hypertension is one of the most common complications during pregnancy and is a leading cause of maternal and perinatal morbidity and mortality, accounting for 8 to 6% of all pregnancies. It can be classified broadly into different types. That is the gestational hypertension, preeclampsia, which can be one without severe features and those with severe features, chronic hypertension, and chronic hypertension with superimposed preeclampsia. Let us define these different terminologies. What do you mean by gestational hypertension? Gestational hypertension is defined when a systolic blood pressure is more than 140 or more and a diastolic blood pressure of 90 or more, or both, for first time after 20 weeks of pregnancy. They usually resolve within 12 weeks of postpartum, and they are not associated or any other systemic findings. Postpartum. Chronic hypertension is defined as a systolic blood pressure of more than 140 millimeters of mercury or a diastolic of more than 90 millimeters of mercury or both, which has been there before the start of pregnancy or has been diagnosed before 20 weeks of gestation. Chronic hypertension with superimposed preeclampsia. This is a new onset proteinuria of more than 300 milligram per 24 hours after 20 weeks of gestation in a previously hypertensive patient, or it can be defined as a sudden increase in proteinuria or hypertension or other manifestations of preeclampsia after 20 weeks of gestation in a patient who was already hypertensive and had proteinuria before 20 weeks of gestation. Coming to preeclampsia. Preeclampsia is defined as a systolic blood pressure of more than 140 or a diastolic of more than 90 on 2 occasions, at least 4 hours apart, after 20 weeks of gestation in a pregnant patient who was previously normotensive and is associated with proteinuria, which can be defined as 300 milligram or more in 24 hours unit collection, or a protein is to creatinine ratio of 0.3 or more, or a dipstick reading of +2. However, presence of proteinuria does not define preeclampsia. In case it does not have preeclampsia, but has any one of these following new onset hypertensive features like platelet count of less than 1 lakh or a renal insufficiency, which can be defined by a serum creat of more than 1.1 milligram per deciliter, or a doubling of a serum creatinine concentration in absence of any other renal disease, or an impaired renal function, which can be defined by the elevated blood concentration of liver transaminases to twice the normal concentration, or a pulmonary edema, or any new onset headache unresponsive to medication and cannot be accounted by any alternative diagnosis or a visual symptoms present. So in case you don't have proteinuria, but you have any one of these features, again, it can be classified as a preeclampsia. Coming to severe preeclampsia, wherein the systolic blood pressure is more than 160 and a diastolic of more than 110 or both, and has got the features of platelet count of less than 1 lakh, has renal insufficiency, impaired liver function, has a pulmonary edema, and a new onset headache unresponsive to medications and not responding to treatment. There is something called as the early onset or a late onset preeclampsia. Now, this is defined basically by the onset of these symptoms. If it is before 34 weeks, but after 20 weeks of gestation, it is said to be early onset, or if the symptoms appear after 34 weeks of gestation, is said to be late onset. The basic difference is that since it is a late onset, the risk outcomes are negligible. However, they account for majority of the cases of preeclampsia, accounting for 80% of the patients. The risk factors are basically diabetes, hypertension, increased maternal age, or obesity and serious disorders, whereas the early onset has to have a familial disposition. Coming to eclampsia, which is a new onset of seizure or unexplained coma during pregnancy or postpartum in patients with pre-existing preeclampsia and without a pre-existing neurological disorder. Most seizures are interpartum or within the first 48 hours of delivery. So what are the risk factors? They can be classified as demographic factors like an increased maternal age of more than 35, black race, genetic factors like previous history of preeclampsia in previous pregnancy, or a history of preeclampsia in the mother, or there's a history of placental abruption, fetal growth restriction, or fetal death, or a partner who fathered a preeclamptic pregnancy in another woman. Medical conditions such as obesity, hypertension, diabetes, chronic renal disease, antiphospholipid antibody syndrome, or SLE also account for increased chances of PIH. Obstetric conditions like multiple gestation or hereditary form mole, behavioral factors such as non-smoker, and partner-related factors like nulliparity or limited preconceptional exposure to paternal sperms are said to have high risk for PIH in the pregnancy. Coming to etiology and pathogenesis, the exact cause is still unknown. However, there are various theories which are said to be responsible for PIH. One is abnormal placentation or the genetic factors, immunologic factors that the uterine natural killer cells, imbalance between the thromboxanes and the prostacyclins, or the anti-angiogenic proteins like soluble endoglyns or SFLT. Now, how does it happen? So initially, there is a poor placentation. Now, poor placentation can result in fetal growth restriction, or because of poor placentation, there can be oxidative stress on the placenta, which results in increased release of the systemic factors. Systemic inflammatory response sets in and endothelial activation, and this results in preeclampsia. There are certain biochemical markers for PIH, such as increased plasma homocysteine or increased soluble FMS like tyrosine kinase, or decreased serum and urinary platelet growth factors, or decreased vascular endothelial growth factors. How can you predict whether the patient is likely to have PIH? There is no screening test as such which is available. However, there are certain screening methods which can be used, such as the ultrasound using a Doppler, which gives a diagnostic diastolic notch at 24 weeks, or an absence or reversal of the end diastolic flow, or an average mean arterial pressure of more than 90 millimeters in the second trimester, sorry. The other are the infusion test and the rollover test. Coming to the clinical manifestation, how does PIH affect the different organ systems of a pregnant female? Starting with the cardiovascular system. So there is an increased vascular tone and sensitivity to vasoconstrictors, which results in hypertension, vasospasm, and end organ ischemia. So the resultant is increased blood pressure and increased systemic vascular resistance. There is an intravascular volume depletion because of the vasoconstrictive state in these patients. Majority of the patients tend to have a hyperdynamic circulation with hyperdynamic LV function. However, small high-risk groups can also have the opposite. That is, they may have a decreased LV function, markedly decreased SVR, and decreased intravascular volume. Coming to the respiratory system, there is an increased pharyngolaryngeal edema, and there is an increased risk of pulmonary edema seen in this subset of patients owing to the lower colloid oncotic pressure and increased hydrostatic pressure and increased vascular permeability. Hematologic system, there is thrombocytopenia, which can be seen in 15 to 20% of the patient, and hypercoagulability is seen without severe features. Renal function, there's a decreased GFR with increased proteinuria, increased urine protein is to creatinine ratio, and oliguria can be seen in these patients. In the hepatologic system, there's a periportal hemorrhage or a fibrin deposition in the hepatic sinusites. There are increased serum transaminases and hepatic edema, or the right upper quadrant abdominal pain can be seen, which is suggestive of the rupture of the Glissen's capsule of the liver. Coming to the endocrine system, wherein one sees an imbalance between the prostacyclin relative to the thromboxane, and there is an upregulation of the systemic renin, angiotensin, aldosterone system. The uteroplacental circulation sees a persistence of a high resistance circuit with decreased blood flow, which can result in IOGR and oligohydramnios. Lastly, the ophthalm. In this, the eyes, what you see is the retinal arteriolar vasoconstriction. There can be retinal detachment, blindness, and even disc edema can be seen in these patients. So the fundoscopy can help us to appreciate if there is an increased severity of PIH in these patients. The uteroplacental circulation, there is uterine and intervillous blood flow, which is diminished by 50 to 70% in these patients because of hemoconcentration or increased blood viscosity with vasoconstriction, which results in decreased placental perfusion, placental ischemia and infarction, placental abruption, preterm labor, IOGR, and final could be a fetal loss in these patients. The complications of preeclampsia can be maternal or fetal. In maternal, we can have antepartum hemorrhage. There can be CVA, eclampsia, pulmonary edema, as we already talked about, because of the increased permeability of the membrane, HELLP syndrome or DIC, hepatic failure or renal failure. In fetal, there can be IOGR, there can be preterm birth or IUD. The lab investigations which are routinely done in these patients should be CBC, a urine routine and microscopy to check for proteinuria, LFTs to see for any organ dysfunction, RFTs, serum electrolytes, RBS, the coagulation profile, which can be deranged in subset of patient, a fundoscopy, which will help us to estimate how much is the severity of PIH in this subset of patients, ultrasound of the abdomen with Doppler, which can help us to realize whether there is an increased size of the liver because of maybe a ruptured hepatic rupture. And also we'll talk about the ultrasound features of the placenta that we already talked about. And lastly, blood grouping and cross-matching should be done in all patients. How do you manage a patient of preeclampsia? So firstly, there should be a maternal surveillance so that you should see that the severity of these symptoms are not progressing, whether the patient is in a stable condition or do we need to intervene and need to end the pregnancy at the earliest, terminate the pregnancy at the earliest. Then is the fetal surveillance to see whether the child is not undergoing an IOGR or an towards the IOD. So in case the child does not have a proper growth, there is no need of continuing with the pregnancy, and the earliest termination of pregnancy should be planned. And lastly will be the induction of labor, or should be done if one can reach up to 37 weeks, or after 34 weeks, one can very well go for a termination of pregnancy. So management of preeclampsia, firstly, the patient should be hospitalized, should be started on antihypertensives, should optimize the intravascular volume, monitoring of fetal and as well as the maternal monitoring is very essential. You should administer corticosteroids in case the pregnancy is before 34 weeks so that the lung maturity of the fetus can be attained in case one has to go for an emergency LSCS. Anti-seizure prophylaxis should be watched for. Vaginal delivery is preferred in these patients, and the timing can be anytime after the 34 weeks is perfectly ideal as the lung maturity has been attained in the fetus. In case we have to terminate the pregnancy because of any maternal or fetal indications, one should be watchful. Expected management till 34 weeks may improve the fetal outcome. Delay of 24 to 48 hours, if possible, should be given so that the steroids can act towards the lung maturity of the fetus, and maternal and neonatal ICU facilities should be available as these patients are high-risk subset. To expedite delivery, regardless of the timing and steroid therapy, it is done in certain cases such as a HELP syndrome, placental abruption, or pulmonary patient is in failure, there's an eclampsia, refractory hypertension despite the optimal medical treatment in these patients, there's persistent cerebral symptoms despite starting with magnesium sulfate, or a non-reassuring fetal status. So in that case, one has to go for a delivery of the child irrespective of the time of pregnancy. Coming to management of the HELP syndrome, you require immediate hospitalization. You need to stabilize the mother, start on antihypertensives if they are not ongoing. Seizure prophylaxis should be started in these patients. Correct for the coagulation abnormalities because these patients are likely to undergo the emergency LSCS. So you should optimize the patient at the earliest. Assess for the fetal conditions, and general anesthesia would be the preferred choice in these patients as they tend to have deranged coagulation profile. So regional will be a contraindication in these subset of patient. Other than this, one has to see for seizure control and neurologic assessment, treat and prevent any further complications, fetal monitoring to deliver a vital fetus, and lab investigations which will help us to investigate and to improve the condition of the patient. Now, how do you go about controlling hypertension? Generally, it requires an invasive blood pressure monitoring if the patient is hospitalized. If not, one can very well go for a non-invasive blood pressure monitoring also depending upon the setup. The target should be to attain a systolic blood pressure between 120 to 160 or a diastolic between 80 to 105, which will depend upon the primary baseline reading of the patient. So do not lower the mean arterial pressure more than 15 to 20% to avoid any precipitous fall because it will then affect the uteroplacental circulation. Most commonly for acute control, one may go for hydralazine or labetalol is the drug of choice in these patients. Nifedipine may be used, but an unexpected hypertension is seen, especially when it is given along with magnesium sulfate. For a refractory hypertension, one may go for a nitroglycerin or nitroprusside infusion, but with nitroprusside, one may see that the child may have a cyanotoxicity, so one should be watchful. It should be a last resort. ACE inhibitors and angiotensin receptor blockers are contraindicated because of the adverse effect on the fetal and the precipitous hypertension that is seen with the use of these drugs. Coming to optimization of the intravascular, we talked about that the intravascular volume is depleted in these patients. However, we also talked that there is an increased permeability. So in case one needs to overload these patients, there is likely chances of the fluid going into the intravascular, cellular space and interstitial space, and can result in pulmonary edema. So a judicious use should be done to prevent pulmonary edema. Maintain the maintenance fluid around 1 ml per kg per hour. Urine output should be watched and should at least be 0.5 ml per kg per hour. Colloids should be avoided in these patients. A hematocrit of less than 27 is not acceptable, and in such cases, one should go for blood products, but again, keeping in mind that you do not overload your patient. Seizure prophylaxis should be started routinely in preeclampsia with severe features. Magnesium sulfate is the drug of choice in these subset of patients, and they should be continued 24 hours postpartum as well. For cesarean, start at least 2 hours before the cesarean section till 24 hours of postpartum period. One should be watchful that when you're giving magnesium sulfate, and the drug would have effect if you are giving maybe a general anesthesia or a regional anesthesia. So those implications should be kept in mind, which has been discussed very nicely in the case discussion. Now, how does it act as an anticonvulsant? It reduces the cerebral vasospasm by vasodilating the cerebral vasculature. Vasodilation causes decreased peripheral vascular resistance, and they also act on the central NMDA receptors, and they raise the seizure threshold in the patient. The recommended regime can be an IV regime, which is a Zuspan regime, or a Pritchard, which is an intramuscular. So depending upon the regime that you choose, you can go ahead, you can decide the dosage of the magnesium sulfate that you want to give. But when you're giving magnesium sulfate to the patient, you should be watchful that it is between the therapeutic range only and does not cross the therapeutic range. So a serial monitoring of magnesium sulfate should be done, and a clinical assessment can be done by watching the respiratory rate, the knee jerk reflexes of the patient, and the urine output of the patient. So these three are the very essential part of clinical judgment of whether the patient is going towards magnesium sulfate toxicity. So the therapeutic range of magnesium sulfate is 4 to 8 milligrams per deciliter, and anything beyond that, one should be very watchful. You can down titrate the amount of magnesium that you're giving to the patient. The effect of magnesium sulfate, we already talked about how does it help. Now, what does it do, and how does it affect the anesthetic consideration in a patient who is already on magnesium sulfate? Firstly, it interacts with the non-depolarizing muscle relaxants, so their actions will be prolonged. So you need to do a neuromuscular monitoring, or you need to down titrate your dosage of the non-depolarizing muscle relaxant. It also affects the tone. It is a tocolytic, so it affects the uterine tone, and it also interacts with the calcium channel blocking agents. Okay, so basically it inhibits the release of the acetylcholine from the NMJ. It can act as a tocolytic agent. So these are the things that we already discussed. Now, what are the side effects? Again, we've already talked about the side effects depending upon the level of the serum magnesiums. How do you go about treating in case you land up with a magnesium sulfate toxicity? So in that case, the drug of choice is calcium gluconate, which should be given slowly IV 1 gram over 10 minutes. And in case of respiratory compromise, one need to assess. The ABC has to be maintained. So a tracheal intubation with mechanical ventilation should be undertaken so as to manage these patients. Coming to the treatment of eclampsia. Now, if the patient throws seizure, what should be your drug? How should you manage these patients? So again, the ABC should be done. That is, you turn the patients toward the left side and give a jaw thrust to have a patent airway, secure your airway with a bag mask with NPA, supplement oxygen, have essential monitoring, secure an IV access, and monitor the blood pressure. If you have not started these patients on magnesium sulfate, or the patient has already thrown seizure when the patient has come to the emergency, so immediately you should start them on magnesium sulfate. And to end the ongoing seizure, either you can go for a barbiturate or you can go for a benzodiazepine in the form of midazolam. Despite these, if the seizure persists or the patient is not breathing, and then a rapid sequence induction with cricoid pressure and intubation should be performed in these patients, and the patient should be electively ventilated. What are the anesthetic management? Now, the role of anesthesiologists in these subset of patients can be to provide labor analgesia, can be to provide anesthesia either for an emergency LSCS or an elective LSCS, or resuscitation of these patients. And lastly, if the patient has been transported to ICU, then a critical care management, or because of any perioperative complication, they might land in ICU, and you might have to manage these patients in the ICU setup. So coming to labor analgesia. So the ideal technique of labor analgesia in these patients would be a lumbar neuraxial analgesia. Okay, but how does it help? So it helps because it provides adequate and good analgesia, which attenuates the hypertensive response to pain. One may circumvent the complications with GA in case one has to go for a cesarean section in these patients. If the epidural catheter is already in situ, one can start giving drug through the epidural catheter, and it can easily be converted to a regional technique if there are no other contraindications for a regional technique. Catheter placement in the setting of declining platelet count. So you should put the catheter at the earliest, because you never know, the patient later on might have a decreased platelet count, and then it can be an absolute contraindication. And it is also beneficial in improving the uteroplacental circulation. Now, when to deliver? When to deliver will be based on the maternal indications, which we may not be discussing, not required. Fetal indication, again, which can be decided by the obstetrics. Now, what are the pre-anesthetic considerations in these patients? First is the condition of the patient. The mother has to be stabilized. Okay, in case the patient already has a surging blood pressure, you need to start her on antihypertensives before you go either for a regional technique or for a GA, depending upon the indication of the LSCS. The risk of seizure has to be kept in mind. The patient has an anticipated difficult airway. So be sure that you have your difficult airway cart. You have a experienced anesthesiologist who's dealing with the obstetric cases, and you have a help in hand in case you land up with a difficult airway to call for help, right? The other thing will be anti-aspiration prophylaxis. You have to keep in mind that they have a reduced plasma volume. So they may have, you have to be very careful about the amount of fluid that you're giving to these patients. Risk of pulmonary edema, if you overload these patients, they may have an underlying coagulopathy. Renal dysfunction, hypoproteinemia, liver dysfunctions can be seen. These patients can be on magnesium sulfate. So you should be careful when you're giving non-depolarizing muscle relaxant, and a neuromuscular monitoring should be done in these patients. And last but very essential is fetal monitoring. At all points of time, you should go for a fetal monitoring. If you are not able to do that, then it's the job of the obstetric to make sure that the child is absolutely fine till the time you don't deliver. Because then it will decide whether you want to go for GA, or in case the child is, there's a non-reassuring heart rate of the child, then you have to immediately go for general anesthesia in these patients. Investigations, we already discussed. Monitoring will be the basic ASA standard monitoring. Other than that, additional parameters can be observed, like intra-arterial blood pressure or central venous cannulation can be done, but that will be case-based. It need not be done in all the patients, but you feel there's a need because of the antihypertensives, maybe the requirement is too high. You want to observe these patients post-operatively in the ICU because you need to down titrate your hypertensive drugs, then an arterial line will be beneficial. CVP, again, it does not have much role in the fluid management, but a trend may help you. And in case the patient requires any other drugs which should be administered via the central route, again, it will be a help to you. Before induction, make sure you have a wide gauge cannula available. You have given your antihypertensives or the anticonvulsant like magnesium sulfate. Anti-aspiration prophylaxis should be given, and adequate pre-oxygenation is mandatory in all these patients. As an OBS patient, all OBS patients should be pre-oxygenated if you're going for general anesthesia in these patients. So quickly go on to the regional technique. So if the regional anesthesia is the most preferred, if there is no contraindication, we would go for a regional anesthesia technique, which has been beautifully discussed in the case discussion. What are the advantages of regional anesthesia over general anesthesia? So let's not go into that. Now coming to neuraxial. So neuraxial technique, if you're giving, then platelet count becomes very essential. So if the patient has just a low platelet count, that does not mean that the female is not a candidate for regional. You should see the patient as a whole. You should see whether the patient has any other organ dysfunctions, which can be a contraindication for neuraxial. If there is no coagulopathy, your PTINR is absolutely normal. It is just an isolated reading of platelet count. In that case, one may go for regional anesthesia, provided it is more than 80,000. If it is more than 80,000, you can very well go. Between 50 to 80, that is the gray zone where you have to be watchful. You have to see there is no underlying coagulopathy, and there are no other problems associated with the neuraxial. General anesthesia, The hazards of general anesthesia, as we all know, is the manipulation of the airway. Again, this patient is hypertensive, so any airway manipulation, the stress response will be exaggerated. The surgical stress response will be exaggerated. So it becomes all the more difficult for you to maintain the stable hemodynamics in these subset of patients. You can land up with a difficult airway. They can be when the patient is in active labor, the Mallampati grading would further worsen, and you may land up with a difficult airway again. So magnesium sulfate, again, it has a role in interfering with the your neuromuscular blockade. So you need to be watchful. And impaired hepatic or renal blood flow may affect the drug metabolism and clearance, and they are at high risk of aspiration. So induction has already been discussed that you need to be careful. You need to pre-oxygenate these patients. You should ensure that there is an adequate large bore cannula that is available. Anti-aspiration prophylaxis has been given. A difficult airway cart is available. You apply a cricoid pressure, go for an RSI in these patients, and the drug of choice would be thiopentone in these subset of patients with the depolarizing muscle relaxant to go for a RSI, right? And in case the patient already has a higher BP, so first try and control your blood pressure before you jump on to giving the drugs for general anesthesia. So take your time, control the blood pressure before you jump onto your general anesthesia for these patients. You need to other than that, the other thing that one has to keep in mind is the stress response to laryngoscopy and you're going for general anesthesia. So in that case, one can go for lignocaine, that is your Zylocard, or else you can go for opioids also. But one thing you need to be careful, since you're going for an RSI, you would be giving thiopentone, which will act in seconds. You may not have 90 seconds time frame, so better give Zylocard before you start with your induction agents. In case of giving opioids, again, you can give opioids in a lower dose, and but you have to tell the pediatrician that opioid was given in case the obstetrician faces difficulty with managing the child. So he can keep opioids as one of the differential diagnoses. So what are the advantages of regional versus general anesthesia, which has already been very nicely covered? So to conclude, PIH is a multi-system disorder. The management is supportive and delivery is the only definitive route to treat this complication. PIH patients are at high risk for difficult intubation and other systemic involvements that are there. And hypertensive response to laryngoscopy may lead to intracranial hemorrhage. Spinal anesthesia is not contraindicated in severe preeclampsia or even eclampsia. In case the patient is fully conscious, there is no contraindication to regional, and there are no indications of high intracranial pressure. Eclampsia can be prevented by prophylactic magnesium sulfate therapy. Eclamptic patients should be monitored for at least 24 hours postpartum, and magnesium sulfate is now proven as the best medication to prevent as well as to treat eclampsia. Epidural analgesia for labor pain management and regional anesthesia for cesarean section has many beneficial effects and should be preferred over general anesthesia until contraindicated or there is an obstetric indication to give general anesthesia in these subset of patients. Thank you so much.
Okay, so I can see one question in the chat box. So question is, how long should elective mechanical ventilation, how long is it indicated if patient had seizure and we have taken up emergency breathing section? So the answer to this is that at least around 24 hours, because as for any patient with raised ICP, we must give a period of 24 hours along with other supportive measures for it to settle down, and then reassess the patient again after 24 hours in terms of seeing the consciousness level when you taper off whatever sedation you are giving and muscle relaxation. If the patient is still not okay, then you may have to continue for longer, but at least 24 hours. So I think that brings us to the end of the session.
Thank you, ma'am. Thank you so much. It has been always a pleasure to have you on board, and it was such a nice discussion. And thank you, Dr. Nitin.
Thank you so much, ma'am.
Now we'll move on to the next session, which is very interesting. That is drug viva, in which we will be discussing about the opioids. The examiners will be here Dr. Neerja Banerjee. She is a professor anesthesia in Atal Bihari Vajpayee Institute of Medical Sciences and Dr. RML Hospital. Her area of interest are critical care and neurosurgery. She is a ATLS and CCLS instructor.